So how is it that a drug that at one time was really just viewed as a street drug that was bad, 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 is now being prescribed widely and has all this interest surrounding it? And really this has to do with our understanding of what depression is and what depression isn't. So I'd like to just take 1 or 2 minutes and explain to you a little bit about the history of depression and its treatment. What we observed starting about the middle of the last century, so around 1950, but really taking off in the early 1980s and 90s, is the so-called monoamine hypothesis of depression. Monoamines, as the name suggests, are synthesized from amino acids. That's a good way to remember monoamines. Monoamines include things like serotonin, dopamine, and norepinephrine, although there are other monoamines as well. Monoamines are neurotransmitters, or more specifically, they are neuromodulators, meaning they change the activity of neural circuits in the brain and body. They can ramp up levels of activity in lots of different brain areas, or they can reduce the activity of neural circuits in lots of different brain areas, as well as within the body, right? Your gut has serotonin and needs serotonin. Dopamine also plays important roles in the body, et cetera, et cetera. The monoamine hypothesis of depression is really centered around the idea that it is deficiencies in these monoamines, either serotonin or dopamine or norepinephrine, or some combination of those that gives rise to depression. Now, in reality, there is very little, if any, evidence that there is a deficiency of monoamines in any form of depression. However, it is very clear that drugs that increase certain monoamines, so drugs like Prozac or Zoloft that increase serotonin, or drugs like bupropion, which is often called Wellbutrin, which is its commercial name, which increases dopamine and norepinephrine, can often provide relief for certain symptoms of depression in some people. However, what we've learned over the last 30 or 40 years is that drugs that are designed to increase certain monoamines in order to treat depression only work in about 40% of depressed people that take them. And they have a lot of side effects. Now, some people are lucky enough that they can use a low enough dose, or perhaps even a high enough dose that gives them relief from their depressive symptoms, but does not give them side effects that make it so uncomfortable for them to use that drug that they would choose rather to not take that drug. However, a lot of people that do get depression relief from things like Zoloft or Paxil or from bupropion find that the side effects, which include things like dry mouth, although more commonly reductions or increases in appetite, or vast reductions in libido, or changes in their sleep patterns, etc., that those side effects really make it impossible or at least very uncomfortable for them to take those drugs. And of course, there are the 60% of depressed people who do not respond to those drugs at all. Now, I want to be very clear. Things like SSRIs, things like Wellbutrin have helped a tremendous number of people get relief from depressive symptoms, and in many cases have warded off suicidality as well. However, there are also a great number of people who have experienced a lot of side effects and problems from these drugs. Hence the desire to find other compounds that can treat depression without creating similar side effect profiles, and that ideally can provide relief not just for 40%, but for all people suffering from depression. So that's where ketamine enters the picture. Prior to the 1990s, they were mainly studied in neuroscience and pharmacology laboratories for their abuse properties and for their anesthetic properties. So ketamine is a dissociative anesthetic. It's actually used to induce certain forms of anesthesia for surgery. It's not always used, but it's often used. This is something that if you've ever had a surgery, you might want to ask your anesthesiologist about, what sorts of drugs are you giving me to go under? What sorts of drugs are you keeping me to stay under? And maybe even what sorts of drugs are you giving me to bring me out of anesthesia? Because it turns out that when you go into anesthesia, your anesthesiologist is rarely giving you just one drug. Typically, they're giving you one drug to, kill off a little bit of anxiety and maybe eliminate a little bit of pain sometimes. And then they'll give you another drug to drop you into a deeper plane of anesthesia. And then nowadays, there are sophisticated ways to monitor your plane of anesthesia. And there are sophisticated ways to, if necessary, get you out of a deep plane of anesthesia if that plane of anesthesia is too deep. When I talk about a plane of anesthesia, I'm just talking about going from full wakefulness to a reduction in anxiety, to falling asleep, to the point where even if someone were to pinch your toe or your arm, like a really intense pinch, that you wouldn't wake up from that. Okay, so ketamine has the property of being an anesthetic. It kills the response to pain, and at certain doses, it can bring you into deep planes of anesthesia. At lesser dosages, it can take you into transition points between awake and deeply anesthetized. And it's really that transition point between awake and deeply anesthetized, which we are going to call the dissociative state. It's kind of this liminal state, a little bit like dreaming. It can have some dreamlike qualities to it. That's the state that has most often been sought after or employed for the treatment of depression, suicidality, and PTSD. Which brings up a really important point, which is that when people use ketamine recreationally, it's not clear exactly what plane of anesthesia or dissociation they are actually seeking. And this is why we hear about some of the desired effects of ketamine that are driving people to use it recreationally, and why we also hear about people having some unpleasant or even very unpleasant or dangerous experiences when using ketamine recreationally. Because we're talking about a drug that has a lot of different effects depending on the dosages, and as we'll soon talk about, individuals vary tremendously in their response to different dosages of ketamine. And the delivery route for ketamine, whether or not it's delivered orally in the form of a pill or put sublingually in what's called a troche that dissolves under the tongue, or it's injected, whether or not it's injected into the vein or intramuscularly, et cetera, each of those can produce very different effects in terms of the speed of onset of the drug and the type of effects that it produces in the brain and body. So what happened in the early 90s is that laboratories that were studying animal models, what we call preclinical models of things like depression and learning and memory, and to some extent ketamine, but mainly focusing on learning and memory and depression, made an interesting discovery. There's a certain preclinical model of depression that's pretty common in laboratories that involves taking a rat or a mouse and putting it into a small container, like it looks like a beaker or a jar. Sometimes it's a tray, and it has water in it. And you might be surprised to learn, perhaps not, that if you put a rat or a mouse into water, it will swim. Okay, so it's treading water in order to keep its head above water and not drown. I realize for some of you, this might be a bit of an aversive topic to hear about animal research, but this is one of the common preclinical models of depression, which is put a rat or a mouse into water, let it swim, and see at what point it gives up. Because what happens is if you put a rat or mouse into water, it will attempt to save its own life by swimming, but at some point, it will just give up and it will just start sinking. And then, of course, the researcher needs to rescue the rat or mouse, put it back into its home cage, dry it off, give it some food, etc. This preclinical model is called the model of learned helplessness. And it's become a prominent preclinical model of depression because, of course, we can't ask mice or rats if they are depressed or happy. I suppose you can ask them, but they're not going to answer in any kind of meaningful way. So we can only look at their behavior in order to understand whether or not they have a sense of happiness or a sense of depression. And of course, that's very hard to gauge in an animal model of any kind. You could make guesses based on other behaviors, like are they grooming regularly? Are they eating regularly? You know, things that more or less parallel what we think of as health or lack of health in a human who's happy or depressed. But in the context of trying to understand depression in these preclinical animal models, having a behavior that you can really quantify carefully across a lot of different animals and conditions is really beneficial. So this thing of putting a rat or mouse into water and seeing how long it takes before they give up to save their own life is called the model of learned helplessness. And what it allowed researchers to do was to take rats and mice, put them into water, see how long it took before they gave up, and then to give them different drugs to see whether or not any of those drugs either hastened, sped up, or prolonged the duration over which the animal would attempt to save its own life. This actually has some meaningful parallels to human depression. You know, one of the hallmarks of depression is that people stop thinking positively about their future. Depression, of course, can include a lot of other symptoms. You know, one of the most prominent symptoms of depression, for instance, is consistently waking up around 2:30 or 3:30 in the morning and not being able to fall back asleep again. Now, keep in mind, it is not the case that if you're waking up at 2:30 or 3:30 in the morning and you can't fall back asleep, that you are absolutely depressed. That's simply not the case. But that pattern of lack of sleep, plus some other things like lack of anticipation of a positive future, inability to imagine the future in any kind of meaningful or positive way, etc., are part of the key features of what we call a major depressive episode.